Good morning. As a March of Dimes volunteer for greater than 20 years, I am excited and honored to introduce our next speaker, the president of the March of Dimes, Stacey Davis Stewart. Ms. Stewart joined the March of Dimes as the 5th president on January 1st, 2017. In this role, she heads the organization leading the fight for the health of all moms and babies. And she's responsible for all aspects of the organization's strategy, vision, and operations. Ms. Stewart came to the March of Dimes from the United Way Worldwide, where she held several positions, most recently serving as president of the United Way, the nation's largest nonprofit organization. There, she provided strategic directions for more than 1,000 local United Ways, spearheading their transformation into a leading organization with local community impact. A business veteran, Ms. Stewart has also held a number of senior roles, including Chief Diversity Officer and Senior Vice President for the Office of Community and Charitable Giving at Fannie Mae, as well as President and Chief Executive Officer for the Fannie Mae Foundation. Additionally, Ms. Stewart has an extensive background in finance and investment banking, having served as Vice President for Pryor, McClendon, Counts and Company, and as a Senior Associate for Merrill Lynch, specializing in financing for state and local governments. As an accomplished leader, Ms. Stewart has a Master's of Business Administration in Finance from the University of Michigan and a Bachelor of Arts in Economics from Georgetown University. She holds many honorary degrees and serves on several national boards. Under Ms. Stewart's tutelage, the March of Dimes launched a new prematurity campaign collaborative to advance equity and reduce premature births. She provided critical insight into the importance of improving the health of mothers in order to have stronger babies. I now present to you Stacey Stewart, a dedicated trailblazer, an exceptional visionary with strong determination and passion, guiding the mission of the March of Dimes through the future. Thank you.
Thank you. I need Dr. Guillory with me everywhere I go so I can feel good. That's a good boost of self-esteem to start the morning with. Thank you all so much for inviting me. And Charlotta is has been an amazing leader in Texas, nationally. She's also been an amazing volunteer for us at the March of Dimes, and I want to thank her for all that she does, not just introducing me, but for all that she does. And she's just an inspiring person on top of it. And I also want to thank Dr. David Lakey, who you all know very well, who's been instrumental in making this happen today. This is really a model for the way I think states can come together to focus on the needs of moms and babies. And I'm not surprised that Texas is leading the way when you've got leaders like so many of you, and Dr. David Lakey, who also happens to serve on our national board. So I'd like to give both of them a round of applause for their amazing leadership. And there are so many friends and partners of the March of Dimes in this room. I just want to say thank you all for the partnership, for the involvement. We see the March of Dimes as being an organization that is, as you heard from Charlotta, leading the fight for the health of moms and babies, but we can't do this work alone. The only way that outcomes for moms and babies is improved is because of the collective effort of a lot of you all in this room, and certainly with our support and help, we want to make sure that we can turn the tide and really see an improvement in all aspects of maternal and child health, not just in Texas, but everywhere in the country. So thank you for having me here today, and also I will speak for a little bit. I've got some slides to show, a little video to show, but hopefully I'll leave enough room for questions and answers, and would certainly love to entertain any of that and hear what's on your mind as well. This is really an honor for me to be here on day 2 of this conference, and I know what we're doing today is delving into women's health and a lot of the issues that we're facing in this country today, including health inequities that are just really running rampant in this country. And part of what you're doing today is really trying to figure out and dig into what we can do together to address them as a community and as a nation who really care about women and children. I'm going to start the presentation with some stark and, I think, timely insights about the state of maternal and infant health. I know some of these may be things that you've already reviewed in the day or so that you've already been together. But just to frame the conversation that I'd like to have, most of these things won't surprise you, but they certainly are things that we need to be remembering as we acknowledge the fact that this country is the most dangerous developed nation in the world in which to give birth. And that absolutely must change. And as the president of the March of Dimes, I lead an organization that is dedicated to collaborating, to taking the lead, to unite around the change for families and building a brighter future for all of us. Our mission is to lead the fight for the health of all moms and babies, as I mentioned, and we do this in a number of ways. A lot of people know the March of Dimes primarily because of the research that we fund, and that certainly is a huge part of what we do. But I think it's really important to know, and you all have seen other aspects of the March of Dimes, I know certainly here in Texas, we do so many more things than just research alone. Investing in local programs that actually can drive real results. Advocacy is a huge part of what we do, both at the state level and nationally. Educating women, giving them trusted information so they know what to do to become healthy before they're pregnant, during pregnancy, and even after. And then certainly collaboration, this collective idea that together we can make a real change. I've had the honor of leading this organization for the past 2 years, and I have seen a number of issues that we believe are really important to focus on, and that we believe really can make a big difference. And there are certainly things that we've seen in terms of progress over the past couple of years, but there certainly are a lot of other things that we have so much more work to focus on. So before I get into what we can all do to help and to focus on the problem, I just want to be really honest about where we are. The first thing that we all have to acknowledge, and I don't need to say this to you all know this, we have to acknowledge the fact that a healthy baby is not created in 9 months. We have to acknowledge the fact that a healthy baby starts with a healthy mom. And another thing is really clear, and that is that we can't achieve this mission of healthy moms and healthy babies alone. We can't do this work alone, as I've said. Collaboration is really key, and that's not just collaboration from within the health sector. What we have to acknowledge is that we actually need people outside of our own sector to enter this conversation and be in this room with us, and to be at the table of creating solutions and problem solving with us. So as we're here all today, we're all among all of us that whose lives are being touched in all kinds of ways, professionally and personally, with this work. I'm really glad that we can be here today to discuss some of the things that we're seeing, and then also discuss what we at least think we need to help create change. So let me just start with a couple of facts. And I want to start with some of the issues around prematurity, but also maternal mortality, the whole range of some of the biggest issues and the challenges that we face with respect to the health crisis facing moms and babies. Just to state a few facts, as you all know, in this country, 1 out of 10 babies is born prematurely each year, and more than 20% of these premature babies are born to Black women. That's 1 in 5 babies. In this country, rates of maternal death have more than doubled in the past 25 years. There are significant racial and ethnic disparities existing in the area of maternal mortality and morbidity. Women of color are at most risk of facing complications, with Black women 3 to 4 times more likely to die from complications related to pregnancy causes and childbirth causes compared to white women. And that is truly an appalling disparity. So here's another one. And again, I know you all have talked about this as well. More than 700 moms died due to pregnancy and childbirth-related causes each year, and more than 50,000 others experience life-threatening complications. Women who are pregnant and give birth in maternal deserts, and I'll talk a little bit about what that is. Women that are pregnant and give birth in maternal deserts are more at risk since they lack access to hospitals, to OBGYNs, to certified nurse midwives. These are all of the issues that frame our everyday thinking at the March of Dimes. So it should be no surprise that in the fall, should have another slide, click it again, see. In the fall, we launched something that we thought would elevate these issues, help to inform the public about the challenges that we're facing. And we were very intentional about doing this the month before the midterm elections, because we felt if there's ever going to be a change in policy at the federal level, we needed to inform and influence both Republicans and Democrats who were seeking positions in Washington, representing their districts back home. They needed to be clear on what these challenges are. We needed everyone entering this new Congress to understand the fight that we're in every day so that they can be in the fight with us. This fight for us started earlier in the fall when I testified to Congress, speaking to the House Energy and Commerce Subcommittee on Health, talking about the issue of maternal mortality and morbidity. And we also made it clear in our Prematurity Awareness Month this past November, where we took baby blankets on to the Hill to show them and to demonstrate the number of women who die as a result of pregnancy and childbirth. We actually then had a campaign called Blanket Change, where we laid 700 blankets, baby blankets, on the National Mall between the Washington Monument and the Capitol, to bring to the attention of those in Washington, those policymakers, that we need powerful change, that we need a different awareness around the issues that moms and babies are facing. We launched a campaign called Blanket Change, and you'll see some of these blankets. Some of them were a little windblown by the end of the day. But we launched this campaign called Blanket Change. These were some of the women that showed up. These were women actually in this picture who'd had babies that were born prematurely. They heard about the campaign and came out to be with us that day. We laid this memorial on the mall because we felt like so many women's voices were not being heard. And we felt that we all needed to create a clear picture of the problem, and we needed to unite people around potential solutions. What we did was we told the world that it was time for blanket change. In other words, we used that iconic baby blanket that all of you all know. When a baby is born, they're wrapped in that iconic blanket. But what we were saying is that incremental, marginal change is not what we need. What we need is blanket, holistic, transformative change. Because on every measure, moms and babies are not succeeding in our country today. And for the wealthiest country in the world, that just simply shouldn't be the case. So this launched a whole campaign that now is continuing. We just had at the Lobby Day in Arizona, several hundred people came out and did their own blanket change in Arizona to elevate some of these issues at the state level for the state legislature and the governor there. And what is happening now, as you all know, now that we're somewhat recovering from a government shutdown and we're hoping not to get back into another government shutdown, some of the stresses around moms and babies just that we're creating for them unnecessarily every day are actually complicating their lives. And those are things the federal government needs to be aware of as well, that we can't add to the burden that moms and babies are facing, that we actually need to be finding ways in which to alleviate these burdens, because every mom's life matters and every baby's life matters as well. We also know, because we have so many disparities, that the issue of all moms and babies is really important. And when we say all moms and babies, we mean irrespective of your race, your ethnicity, your zip code, your income level, it doesn't matter. That we have an opportunity to address health equity. And as we ignite this conversation around the country, the same conversation that really is happening around our dinner tables and things like that, we felt we needed to bring this conversation to the national stage. Now, I sort of wish we didn't have to hold up blankets as sort of this reminder of where we are as a country. I wish we didn't need to worry about some women more than others. I wish it weren't true that the inequalities of geography and race and social determinants would be putting so many more women at risk, in particular women of color. And that also goes for their babies as well. So I think the question is, who are we talking about here? Many of you work with these women daily like we do. One of the things that we also did to sort of elevate this issue of disparities and inequity in this country is we created several videos. I want to show one to you today that would allow you to see a real picture. It's really a story that we're telling around the issue of preterm birth and the inequities that happen with respect to women of color especially. This was actually a campaign featuring a woman named Gada Lewis, who starts her daily journey to see her premature baby in the NICU in her community, as opposed to other women who simply wake up every day and they go to the room next door into the crib and pick up their baby that was just born. We can see the challenges that so many women of color face, especially women generally, but especially women of color. And so if we have it available, I'd like for you just to see this short video. The video is called First Hug. Hopefully it's there. If we can't get it, I can come back to it. Do you want to give me a sign and I'll come back to it later? If you had seen this video, you would have seen Gada. And again, it's what it is this picture of a woman who is a woman that you've probably seen in your daily work. She's recognizable. She's someone we all know. And again, one of the things that is really, we've done very intentionally and very purposefully at the March of Dimes is as we're focusing on the issue of preterm birth, we've tried to be very clear about the fact that unless and until we deal with health disparities and inequity, we will not see a significant change and improvement in the premature birth rate in this country overall. And that takes a variety of different partners and strategies to reach those women where they are and to provide the different supports that may vary from what other women need just to be able to have a healthy baby. One of the other things that we've been doing to actually try to help inform our decisions is use not just some of our scientific research in the lab, but also look at some of the research and the data that we can use to actually create a powerful argument for why some of these disparities exist in the first place. So this fall, in addition to our Blanket Change campaign, we released a March of Dimes Maternity Care Desert Report. And what this is, and I said I would mention what this is, what we did was we looked at access to care. Where are there hospitals that offer obstetric services? Where are OBGYNs? Where are certified nurse midwives? And what we found is that about 5 million women live in what we call maternity care deserts. These are counties that lack even one hospital that offers obstetric care, that have no OBGYNs, and have no certified nurse midwife. 5 million women. About 10 million women have very limited access. And some of these places are absolutely in rural areas, as you can imagine, but what we know is that some of these maternity care deserts actually exist in urban areas as well. I live in Washington, D.C. as an example. If you know Washington, D.C., you know that it's got the Potomac River on one side that splits D.C. and Virginia, but then there's another river called Anacostia River, and it splits the poorest part of the city with some of the wealthiest parts of the city. Wards 7 and 8 are east of the river, and those are the poorest parts of the city. There is no hospital that can provide obstetric care services in the entire parts of Wards 7 and 8. That's tens and tens of thousands of women who have to figure out how to get across a river, hopefully on a metro, maybe catch a ride with a friend or a family member. But in any case, it could take an hour, sometimes over an hour and a half. If you're high-risk pregnancy, or if you are a woman with certain kinds of health challenges, it puts your life at risk. It certainly puts your baby's life at risk. Almost 150,000 babies are born to women in these maternity care deserts. And this is really eye-opening, to say the least. So what we're saying around all this information is great. Now we know what the challenges are, but we really have to turn our collective outrage into collective action. After all, we can't say that we care about babies if we continue to turn our backs on their mothers. And if we don't deal with the social determinants of health that disproportionately affect mothers, then we're not solving the real problems in this country. So let me just turn the attention to Texas. And again, you all know these statistics and you know the situation here. That's why you're here, because you live and work in these, around these issues every day. But the situation in Texas is worsening just as it is in our country as a whole. There are many measures of the health of pregnant women, new mothers, and infants that are going in the wrong direction. I already talked a little bit about the increase in maternal deaths, but the other issue to be concerned about is the preterm birth rate. And that is the proportion of babies, as you all know, born before 37 weeks of pregnancy. That has gone up for the third year in a row nationally. And we've been tracking these rates, as you all know, the March of Dimes, for a number of years. We produce an annual premature birth report card every year for every state. You can even drill down to certain counties and see how well your county or your states are doing. The overall U.S. preterm birth rate rose to 9.93% this past year. That's the third year in a row. For about 7 or so years, we were seeing a decline, but then the last 3 years, we've been seeing a steady increase. The preterm birth rate for the country, we assign a grade for the country and for every state. The U.S. as a whole has a grade of a C. Texas's preterm birth rate in 2017 rose from 10.4% to 10.6%. That's higher than the national average. And the state overall received a grade of D. Many of the cities in Texas received either a C or a D, with Austin receiving a 9.3, which is a C, San Antonio receiving an 11.9, which is an F. That's not something we can be proud of across this state or across our great nation. And it's certainly not something we can stand by and allow to happen. But hope isn't lost. We're not going to let these realities immobilize us. In fact, just the opposite. We're going to use all of this information as fuel for our actions, to mobilize communities and to stand together with each other, to make change happen across our counties, across our states, and across the country. This is why we've significantly ramped up our engagement efforts to include all women and men. We've typically at the March of Dimes engaged a lot of women who've had babies in the NICU, a lot of what we call mission-impacted moms. What we're saying today is that if babies are more healthy babies are born to healthier women, we need to expand the engagement so that every woman sees herself in this fight with us. And frankly, every man. Every man has a mother, so why shouldn't they care about the health of moms overall? At the March of Dimes, we're focusing on real solutions that actually can create real change. One of the things that we're really excited about is a program that you all are somewhat familiar with, I'm sure, maybe very familiar with. And that's the issue of something that we know as group prenatal care. But what we don't focus on is the fact that right in front of us, there's a solution, a program, that actually drives meaningful evidence-based results. We know that group prenatal care can produce results to reduce preterm birth by up to 40% for women of color, up to 30% for women overall. And so one of the things that we're doing at the March of Dimes is creating a scalable program of group prenatal care called supportive pregnancy care that can be implemented and across every community around the country so that we include more and more women into the supports they need to make sure that they can be healthy themselves and have healthier babies. The video's ready? Okay, if you give me 1 second, we'll come back to it. Thank you. These programs can be very expensive for nonprofits and for hospitals to implement, but what we are doing is trying to make sure that we galvanize philanthropic support and other kinds of resources that can scale these efforts more quickly and get results for more women and more babies sooner. We're also ensuring that issues like the importance of maternal mortality reviews are brought to our lawmakers. Obviously, that's something that right here in Texas you all are working on. We want to make sure that we're a part of and one of the biggest voices on ensuring that social determinants of health that are impacting pregnancy outcomes are included into the solutions that ultimately get implemented to protect more moms and babies. One of the local examples of how this is playing out, I'm talking a lot about things nationally, but I want to tell you that for me, it's great that national things happen, but where the rubber meets the road is at the state and local level. That's why this kind of session is so important, because it is really where women are and the partners that are working with those women on a daily basis that have the solutions and that are willing to put forth the efforts to make sure that outcomes can change. 2 weeks ago, Charlotte and I were together in Houston to launch our Birth Equity Initiative. We have a bunch of partners and volunteers and others who've decided that the disparities exist in Houston are not acceptable and have decided to come together differently to pull in various partners across sectors to figure out and develop a plan to eliminate disparities around moms and babies in Houston. We know that Texas is leading the country in pregnancy-related deaths. Again, you all have been talking about this a lot. As a state, it has also the highest number of uninsured women in this country. We have, to mention the maternal care deserts, the state with some of the highest numbers of maternal care deserts of any state in the country. And I know there are programs like the Healthy Texas Women Initiative that are closing this gap, and this is great, and this kind of effort is really going to go a long way to making real progress. Texas AIM will help hospitals and clinics in Texas carry out maternal safety projects that will improve the quality of services that are provided in hospital labor and delivery departments. There is a lot of progress that is already underway here in Texas, and you all ought to be applauded for that. We want to be a part, too, of helping to drive that kind of success and that momentum, and we think about galvanizing the public's interest and their opportunity and interest in investing in these kinds of solutions is going to help to accelerate the success that I know you all will see over time. We're also continuing to expand other known interventions at the local level to reduce preterm birth rates and maternal health in high-need, high-burden communities. Strategies to reduce prematurity can help prevent other maternal problems. We've had long-standing interventions to kind of scale certain interventions that we know can help address things like preterm birth. For example, making sure that low-dose aspirin is available to more women when they need it. Those kinds of strategies are going to continue, and we hope to add to some of these interventions and working with many of you over time. This effort in Houston, though, is a special effort because what it says is that these local leaders are going to be explicit about their desire and the recognition to address inequity in Houston, and we're very proud of the work they're doing there. In fact, what we're seeing is momentum in driving the similar kinds of interventions and initiatives in Los Angeles, in Atlanta, in Chicago, in Boston, and other major cities, and I'm really excited about the fact that Houston is really creating a model within the March of Dimes system for this kind of work. I want to say something about advocacy because at the end of the day, I think one of the things that we all recognize is that programs, interventions, things that happen in the clinical setting and other areas within the healthcare sector are really critical. But we also believe that we have a policy agenda in this country that is not set up to help us succeed. And so one of the things that we're doing at the March of Dimes at a federal level and at a state and local level is taking a broader look at the social and the structural conditions that lead to these unacceptable disparities in this country. Real differences are based on social factors like educational levels, income levels, housing safety, neighborhood safety, and employment. All these factors make a big difference. Raising awareness obviously is one way to help understand and get institutions really focusing on what solutions are in front of us. But we know that we've got to make a big difference in terms of shifting policy. We had 2 big wins at the end of last year, not just we in March of Dimes alone, a lot of us working together. 2 big advocacy wins, the Preemie Reauthorization Act, which is the only federal piece of federal legislation that actually focuses on funding and support to prevent preterm birth, was passed by Congress, signed into law by the president and at the end of the year. And then one of the other things that I'm very proud of, and Dr. Hollier and so many other people worked on this, is the passage of the Preventing Maternal Deaths Act, which actually then starts the process of more maternal mortality review committees around the country, We think this is a huge step. It is not complete. It is a major first step towards addressing maternal mortality. But what we're seeing is that with a lot of us working together, again, building momentum around these issues, that we think we can build even more bipartisan support for policy change at the federal level, and we certainly hope that we can get more of this done at the state and local level as well. Another piece of legislation is coming up soon that I want to make you aware of is the Newborn Screening Saves Lives Reauthorization Act. That's another bill that will certainly need you all's support, and we're hoping that we can get passage of that as well so that we can actually make newborns healthier by expanding screening and making sure that those models of newborn screening are available and systemically implemented across different states. Now, I just want to say a couple other quick things about some of the other things that the March of Dimes is doing. And again, I started by saying we're doing so many other things, but I started by saying that a lot of you all know us for the research we do, and I can't leave this conversation without letting you know what is happening on the research front. Why don't we yet know the causes of premature birth? Well, I'll tell you one quick story about that. Our chief scientific officer, who retired last year, said to me, he actually was at Baylor for a period of time. He's internationally known, incredible background. He's also a geneticist and OBGYN. He said, you know, Stacey, if we understood how labor and delivery happens, we might understand how to stop it from happening too soon. So how long have women been having babies? It's been a long time. And here we are, and we really don't even understand those mechanisms and how this all occurs. So part of why we have the research agenda we do at the March of Dimes with 6 prematurity research centers. We just opened a new one. That's why you have this Big Ben looking thing on the screen. We just opened a new one at Imperial College in London. 6 prematurity research centers who are all looking at various themes, from the microbiome to genetic influences on preterm birth. We have an incredible group of scientists that are working collectively together. We had an amazing breakthrough with one of our research centers in Ohio, looking and having identified certain gene regions that are associated with preterm birth. Our prematurity research center in Stanford and now also at Imperial have developed a early warning risk of preterm birth test that is in the process of going through trials and could soon be available to make sure that we can predict preterm birth earlier so that we have more time to put in place certain interventions. It doesn't mean that that's the ultimate answer to why preterm birth happens, but if we can assess which women are at greater risk of having a baby born prematurely, that certainly will help us implement and put in place certain protocols that may prevent premature birth from actually occurring. There's a lot going on the research front and a lot going on so many other fronts, but I'll just end this with saying and open it up for some questions and answers. Oh, and show the video before we do. That this work is who we are at the March of Dimes, but it is not, again, going to happen without collaboration and teamwork and innovation and real passion and willing to take real risks to do something differently to change the outcomes. Because I'm pretty convinced that if we just keep trying to do things the same old way, we're not going to get better results. So that means that we have to come together and be willing to put on the table what has to change fundamentally to make sure that more moms and babies are healthy, and that means every mom and every baby. So before I open up to questions and answers, if we have the video ready, I'm hoping, I'd like to just show you again. This is the story of Gada Lewis and her story of her baby in the NICU. Well, that's a beautiful mountain scene, but
But not your video.
taking on it. Okay, well, why don't we do this? If y'all are still working on it, maybe we can open it up for some questions and answers.
Yeah, that would be
Sharletta, and
great.
then-
Well, thank you very
before we're
much,
done.
Miss. Thank you very
Thanks,
much
guys, for
Ms.
trying.
Stewart.
They're really working hard, guys. Let's give them a round of applause.
Thank you very much for an excellent presentation. And if you could make your way to the microphones, we'll begin question and answer session while waiting. I do have one question while waiting. I know that the March of Dimes has a new program on implicit bias. Dr. Mann at the yesterday's conference discussed the case of Dr. Sharon Irving, who died a maternal mortality death at the CDC, and also spoke about Serena Williams. Both of these ladies actually recognized that they had problems. How will the implicit bias program that you have help to address this?
Yeah. Well, I think the whole issue of maternal mortality, as I know you all are looking at, is a multifaceted issue, right? There's no one thing that can be done or should be done. There are probably multiple things that have to be put in place. You know, in looking at some of the statistics, again, you know, there are some rough estimations that a substantial number, maybe even the majority of these cases could have been prevented had there been different protocols, different things put in place. There are certainly efforts around AIM that would help address that. But I think we also have to acknowledge the fact that we have heard from too many women, especially women of color, especially low-income women, who enter into our hospitals, our clinics, a doctor's office, and often are not feeling as though, and this is based on what they have expressed in certain surveys and certain other feedback channels, they're not feeling as acknowledged, heard, respected, and even when they voice their concerns and articulate their issues, their needs are not being met in the ways that they should. And I think Serena and Beyonce and one of the persons that we work with, you may have seen his story and the story of his wife, Charles Johnson. When I testify on the Hill, Charles tells a very passionate story of his wife, Kira, who delivered by C-section their second baby at Cedars-Sinai in LA, and for 10 hours went without the kind of care that she needed, 10 hours, and eventually died. And they found that her abdomen was filled with fluid, and there were signs of it all along the way, and Charles kept articulating the need for emergency assistance and someone to look at Kira, and it never happened. In fact, he was being dismissed, basically. Now, it's not to say that that is the cause in every single case. It's not even to say that every single healthcare provider or hospital or doctor is at fault. That is not what we're saying. But what we are saying is that everyone in this country, everyone has implicit bias. I have it. We all do. What we have to make sure is that if, for any reason, those issues stand in the way of any woman getting the care that she needs, let's take it out of the picture. Let's remove it. Let's make sure we all are going through the kinds of training that we need to make sure that whenever someone presents themselves to us, whenever they come to us, in whatever capacity, that includes, by the way, the front desk personnel. That includes the person at the receptionist. Let's make sure that they all are interacting with any woman in the ways that make them feel comfortable, that make them feel supported by the system, and that's what the implicit bias training. So we acknowledge that within the March of Dimes today, we don't have the internal capacity, expertise to do this, so what we're doing is partnering with people who know what they're doing. So we're in the process of identifying the right partner, and what we'd like to do is go to hospitals, healthcare providers, and say, we'd like to offer this training to you. Guess what? We're gonna go through it ourselves first, before we offer it to anybody, because there's no way we can talk about the need to address these issues if we're not doing it ourselves. So we hope in 2019 to get this program off the ground, and would love to work with many of you all if you're interested.
Can you expand upon that and tell me if you're partnering, for instance, with Dr. Ollier and ACOG? Because we know that in health systems there are annual competencies that must be met based on training for racial equity and how we treat our patients. However, like you showed in your example, the front office person, the secretary, in a health system that requirement is there, and it's a box that's checked a lot of times by health systems. However, maybe looking at how we do those things, and then how that continuity start at prenatal all the way through what we're doing with our discharge resources, all groups getting that training. How's that going to be, I guess, filtered out? Are you partnering with the professional organizations?
Yes, we are.
Tying it to policy in any way? Are we?
So I don't know if
there?
Dr. Hollier knows that we're doing this. I haven't quite downloaded everything with her. But this week, our team was interfacing with AIM and integrating everything that we do with AIM and making sure that it's in complete support of. ACOG has been one of our longest and best partners. So anything like this, we would absolutely do in conjunction with all of the different organizations that we're partnering with. We just found that it's not as readily available, and I'm not sure, what we heard from a lot of our healthcare system partners is they weren't exactly sure where to go to for the best training, and so what we're trying to do is close that gap. Right. To make sure that if that's a desire, if people identify that that's a kind of training that they need. We have been long in the space of professional training for healthcare professionals for many, many decades. So we see this as an extension of what we would be offering and want to integrate it in with all the other work that's being done.
So accessibility for healthcare systems, I think that's a pretty short road to travel to make that happen for the systems. But for the private practices, in the rural locations, that ACOG puts a statement out, which we love. I mean, woohoo, when ACOG supports a major public health idea. But to actually say, physicians, we need your MAs, we need your phone nurses, your first point of contact with these moms to take them seriously.
Yeah. So we would love to expand it as much as possible. Lisa, I don't know if you want to say. The only thing I would say about that is that for a lot of this, we need to move way more upstream.
Right.
I mean, we need to be in the medical schools, and I know there are a lot of medical schools that are already incorporating some of these programs, but nursing training programs, other kinds of programs. I mean, there's no reason why this kind of training shouldn't be incorporated while people are being trained to do, for their professional training.
For their tech.
So,
even at the lower level of education.
I would say it has to be at every level. Any interaction, and this is my view, Stacey Stewart's view, every interaction someone has with a patient. There's a report that the DC Public Health Association did, largely with Medicaid moms, who were also low-income moms, and also they were predominantly Black and Hispanic moms in DC. And their feedback was they didn't even get to the doctor. By the time they showed up and the receptionist said something to them and kind of, had a side eye to them or made them feel less than for showing up, for having a concern, for not knowing how to articulate their concerns, for whatever. The minute that they felt that they were not being respected for who they were was the minute that they decided to go somewhere else for help or not seek it at all. And that's what we're experiencing, is that some women, and then what was even more interesting in that report is that even if it didn't happen to every single woman, the word of mouth spread that you shouldn't go to that clinic, or you shouldn't go to that doctor, or you shouldn't go to that hospital because they're going to mistreat you. And that's the word of mouth that goes on, and that's just in DC. I am pretty convinced, if I look at Austin, Houston, Dallas, Chicago, the experience, I'd probably be able to replicate that same kind of feedback in almost every community where these women exist, because that is essentially what, and if it happens for those women, and if it happens for Serena, if it happens for Beyonce, we're at a point where we simply something is fundamentally broken in terms of how we regard people in this country and what kinds of resources and support they need and deserve and have a right to. And if that's what's going on, then we should probably not be surprised that we have the kinds of outcomes with respect to maternal mortality and premature birth. So it starts with us, and I think then we can start to figure out how we can improve the system overall. Lisa, did you want to add to that? know
I
you
just
have-
wanted to say it's a privilege, ACOG, it's a privilege for ACOG to work with the March of Dimes on this amazingly important work, working with you to address implicit bias at all of these different levels. You have already so eloquently stated the issue, and I just want to say that we are delighted to continue to partner with you to address these issues. And again, it's implementation, it's the changes that we have to make in our everyday lives every single day that are going to make the difference. Thank you.
Thank you.
Thank you very
Now
much.
we're out of time. Do we have, can we
There's
show-
one
it-
oth-
He says it might, oh, I don't know, he says it might work too, so we have another question? Oh, perfect.
Yes, we should be able to see the
Okay,
video.
if we could back it up to the beginning, though, because the beginning is special.
And the only thing, I won't ask a question because it may take a while.
3 seconds. Or that might screw it up, I don't know.
But I do want to mention, because Texas is leading the designation for levels of care, for both neonatal and maternal levels of care, I just wanted to give a pitch out to the March of Dimes that in I think it was 1976, toward improving the outcome of pregnancy, they were the first ones to discuss and push the U.S. toward developing levels of care in NICUs.
Yes.
And again, in 2011, they were very instrumental in talking about designation of a healthcare system. So because of that, we're here today, and I was going to ask you how we're going to use the March of Dimes to, after Texas has really developed this program, move it over into the other states.
Well, the great thing is that we have presence in all 50 states, so whatever develops that looks scalable and we should replicate, we'd be happy to be your partner to figure out how can we roll it out nationally. Thank you.
We have the 2-minute sign, and that's
Yeah.
time for the video.
Yeah,
Thank you.
better late than never.
Thank you.
Okay.
Perfect.
Thanks, everybody.